This is Dr. Karen Winkfield. If you'd like to check her out while we're talking, her website is www.drkarenwinkfield.com, or you can follow her on Twitter at Dr. Winkfield. So some of the things that we want to talk about just today, and we have the privilege of being able to talk to you throughout the year about different topics. But there was a study through the CDC that indicated that African American women have a higher death rate than any other ethnic group. And it says, in fact, they are 40% more likely to die from the disease. So what I wanted to ask you is are these true statistics? There are so many statistics that come out about African American communities, and we're wondering, is this a true statistic? And if it is true, what are some of the contributing factors to the cancer death rate among black women?
So it's a great question, and I wanted to just back up a little bit. That the CDC stands for the Centers for Disease Control. It's a government agency that's down in Atlanta, Georgia, and in fact is one of the organizations that has a kind of comprehensive grasp on what's going on in terms of the health of our nation. And the statistics that they came out with respect to breast cancer, we're talking specifically about breast cancer now, where we find that African American women actually die of the disease at about 40% more than Caucasian women, is absolutely true. Let me tell you how they get their statistics. They are actually these national program cancer registries that probably are able to capture about 96% of what happens in the nation with respect to cancer care. On top of that, they add the data from a database that's called the Surveillance Epidemiology and End Result Database. It's also known as SEER, S-E-E-R database. And they also collect cancer statistics, but really from just a smaller number. But combined with the National Cancer Registries, the SEER database, both of those combined gives you essentially the data that we need to say what's going on in the nation with respect to cancer outcomes. Black women don't have the highest incidence. An incidence is what's the rate of someone developing a disease each year. So white women actually have the heaviest burden of breast cancer.
Really?
Yes, they're diagnosed with breast cancer much more than black women. Now you'll see on those curves, if you go to the CDC website, that since about 2003, the incidence of breast cancer amongst white women has been slightly declining, where it's been slightly going up for black women. Some of that may be accounted for because we're doing a little bit better with respect to screening amongst black women, so that might account for some of that difference, but it's hard to say. But the bottom line is, despite the fact that white women are diagnosed with breast cancer more, black women die of the disease more. And it's a scary statistic.
That's very scary.
And so it does beg the question, why? Why this difference? Why this disparity in terms of the outcomes for this disease? So when you look at the raw numbers, we sometimes look at cancer in terms of overall survival at 5 years, or breast cancer-specific survival at 5 years. And for white women, at any stage across the board, overall survival at 5 years is 90%. For black women, it's 77%.
Less.
Absolutely less. It's 13% less, right? So we're talking a huge difference, and there are some things that we can talk about that may contribute to that disparity.
What do you think contributes to that disparity? Is it just not getting the care necessary to treat the cancer? Is it lack of information?
So it's multifactorial. There's lots and lots of literature that kind of look at and explore what some of the factors may be. We know that the black community is sicker overall, right? So more comorbid disease, more heart disease, more obesity, more diabetes. Yes. And anytime you have those comorbid illnesses, your cancer outcomes are going to be somewhat less. So that may be one thing. So it's a question of, are there social things? Is there biologic things? Are there genetic things? What are they? And it certainly is a complex mixture. The studies do look at socioeconomic status, which we know independent of race. Socioeconomic status, if people are poorer, so poverty level affects outcome, just for the reasons you said, whether it be access or other issues, right? So that certainly can be it. limited access to health care. And here in Boston, where we have an uninsured rate of 1.3%, you would say, oh, well, everyone has access to health care. And I beg to differ. Having insurance does not mean you have access. It means you have insurance. But if you ask people in the community, particularly in the black community, if they feel comfortable going to XYZ institution, many times they won't. Or if you live in Mattapan and you want to get to, say, Dana-Farber or Mass General Hospital because you want to have surgery there or you want to have your exam there, why does it take several hours to get there if you don't have a car? Public transportation. So access is not just about having a piece of insurance that allows you to go to the doctor. There are other things. It's also about feeling comfortable going in. Do you feel welcomed when you walk into that institution?
That's incredible that you said that, because access, you know, on paper, does everyone have insurance? Sure, everyone has insurance.
Yes.
In actuality, they don't.
Correct.
Have access to that.
And it's something to consider now with the new, Obamacare, right? So we're moving into a new realm where this model that's been here in Massachusetts is going to be rolled out around the country. And we have to be cognizant of the fact that just because people have quote-unquote insurance doesn't mean that they have access. And it's a really, really critical piece. I've found that some of my patients who were previously on Medicaid with the new Massachusetts laws were able to get insurance, but they find that they actually have less coverage. For example, they may have had all of their medications covered, where they may have only had a $4 copay or something like that. But with the insurance, their copays go up. But they're in...
Right.
Right? So they're in poverty. And so if they have 10 medicines, each of which has a copay of $20, they have to make a decision. Am I going to feed my family or am I going to get my medicine? So people who may have had chronic diseases like hypertension or diabetes, who previously were well controlled and doing well, all of a sudden now we start to see variability in terms of their health status because they no longer are able to afford their medications.
That's very discouraging. That's very discouraging.
It can be, right? But what we talked about in the beginning before we even started this, you say, well, let's think about what the positives are in this. Massachusetts, in many ways, is going to be a role model for the rest of the nation. So we have the ability right here in this forum, to start asking people questions, to start getting feedback from folks who may have experienced some of this. That's part of the reason why we set up that website, right? You'll see there's a blog there. There's a form for people to actually put in their comments. If people have experienced these sorts of things, what things are preventing them from having access to health care? What are your barriers? Is it family? Is it health care? Is it that your job, you're a salaried employee, so you get paid for the time that you're in your job? And if it takes you an hour and a half to get to an institution, you wait for 2 hours to see the doctor, you see the doctor, then it takes you another hour and a half. When are you going to get to work?
Right.
Okay, so there are people who say, you know what, I've got to work. I get minimum wage. If I don't work today, I don't eat. So, go to the doctor or go to work. They go to work.
They go to work.